Hi, and welcome back to Ready, Set, GYO, your on-the-go guide to learning gynecologic oncology. I'm Sydney.
And I'm Maya. This is a podcast for fellows by fellows. We are here to help you explore the diagnosis and treatment of gynecologic cancers, master the standards of care, and stay on top of new practice-changing publications.
Let's get ready to GYO!
This is our last episode in a 4-part series on uterine cancer. Today, we're going to be discussing uterine carcinosarcomas and sarcomas. Sydney, what are our learning objectives for today?
Our learning objectives are to 1. Discuss uterine carcinosarcomas, including their historical context and unique aspects of treatment. 2. Review the epidemiology and risk factors of uterine sarcomas. 3. Recognize that the FIGO staging of sarcomas differs from uterine carcinomas. 4. Discuss the most common types of uterine sarcomas, including leiomyosarcomas, ULMS, and endometrial stromal sarcomas, ESS. Explore the treatment of leiomyosarcoma in the first-line and recurrent settings. And last, describe management of less common uterine sarcomas.
We're going to start off today's episode discussing carcinosarcoma. These cancers are classified and staged as carcinomas, and they are not sarcomas. However, historically, they were considered to be closer to sarcomas, and as such, they were included in a lot of the earlier sarcoma trials. Carcinosarcomas account for less than 5% of all uterine malignancies, but the incidence has been rising. As with other uterine cancers, carcinosarcomas disproportionately affect patients identifying as Black and are also more common in patients with a history of unopposed estrogen exposure, tamoxifen use, and pelvic radiation. Carcinosarcomas are aggressive, and 60% will have metastatic disease at the time of initial presentation. As such, full body imaging to evaluate for metastatic disease is recommended for these patients. Stage is the most important prognostic factor, and the 5-year survival rate is only 59% for patients with stage 1 to 2 disease, regardless of treatment regimen. When these cancers metastasize, the carcinomatous component tends to be the part that spreads. Surgical staging is identical to other high-grade endometrial carcinomas and should include omental biopsy. Fertility-sparing treatment is not recommended. Carcinosarcomas were included in the Centaur trial evaluating the efficacy and safety of sentinel lymph node biopsy, and as such, this approach is preferred for lymph node evaluation in patients with apparent early-stage disease. Complete cytoreduction, as in other endometrial cancers, is associated with improved overall survival. Up to 1/3 of carcinosarcomas will overexpress HER2, so HER2 testing is recommended for all carcinosarcomas. Sydney, how do treatment options differ for carcinosarcomas than for other endometrial carcinomas?
For early-stage disease, due to the high risk of recurrence and relatively poor prognosis with carcinosarcoma, systemic therapy and vaginal brachytherapy are recommended postoperatively, even for stage 1A disease, with the consideration for EBRT if the sarcomatous component is greater than or equal to 50% of the tumor and the carcinoma is high grade. It's important to start adjuvant therapy quickly, ideally within 3 to 6 weeks postoperatively. For more advanced disease, the chemotherapeutic backbone of carboplatin and paclitaxel is still the preferred therapy. Historically, ifosfamide was considered to be the most active agent in treating carcinosarcomas. GOG 108 tested single-agent ifosfamide plus and minus cisplatin for carcinosarcoma and demonstrated increased response rate, but no improved survival and increased toxicity with the combination arm. GOG 161 then evaluated ifosfamide with and without paclitaxel in patients with stage 3 to 4 disease, including persistent and recurrent disease. This study showed a significant improvement in PFS and OS with the addition of paclitaxel. Ifosfamide has a tricky administration schedule and some unique difficult toxicities, including GU hemorrhage. So there was a push to evaluate alternative options. GOG 232B was a phase 2 study which evaluated carboplatin and paclitaxel as a single arm in a previously untreated advanced uterine carcinosarcoma. This study demonstrated activity with an overall response rate of 54% and acceptable toxicity. Finally, GOG 261, published in 2022, compared carboplatin and paclitaxel versus paclitaxel ifosfamide in a phase 3 non-inferiority trial. This trial found carboplatin and paclitaxel to be non-inferior in both progression-free survival and overall survival, and actually significantly improved progression-free survival. There was a similar rate of toxicities but different distribution, with more confusion and genitourinary hemorrhage in the ifosfamide arm. This study established carboplatin and paclitaxel as the standard of care for carcinosarcoma. As we discussed in the last episode, carcinosarcomas were included in the RUBY trial, and as such, dostarlimab can be added in the advanced frontline setting. Maya, are there any other therapy options for uterine carcinosarcoma?
Carbotaxol and trastuzumab is recommended for advanced HER2-positive uterine carcinosarcomas in the upfront setting based on the results from the FADER publication, which evaluated trastuzumab in uterine serous carcinomas. Until this year, there were no published clinical trials that directly evaluated the use of trastuzumab in carcinosarcomas. The STATUS trial was a phase 2 trial published in 2023, which evaluated the efficacy and safety of an antibody-drug conjugate with trastuzumab deruxtecan in patients that had recurrent HER2-positive uterine carcinosarcoma. Patients were included with HER2 IHC of greater than or equal to 1 plus, and they were then stratified into HER2 high, which was greater than or equal to 2 plus, and HER2 low, which was people with 1 plus disease. The primary endpoint was overall response rate. The overall response rate was 55% in the HER2 high group and 70% in the HER2 low group. Median overall survival was 13 months in the HER2 high group and was not reached in the HER2 low group. This trial presents an important new option for treatment of a disease which, when recurrent, has a dismal prognosis, and it was also novel in the similar response between HER2 1 plus patients and those with more HER2 expression. There's low-quality data for radiation in carcinosarcomas. The use of vaginal brachytherapy is increasing, mostly based on data from other endometrial histologies. That's all we've got for uterine carcinosarcoma, and this closes out our coverage of uterine carcinomas. Sydney, do you want to transition us to sarcomas?
Absolutely. So uterine sarcomas account for about 3% of all uterine cancers and include uterine leiomyosarcoma being the most common, endometrial stromal sarcoma, undifferentiated uterine sarcoma, adenosarcoma, perivascular epithelioid cell neoplasms, also known as PEComas, and inflammatory myofibroblastic tumors, known as IMTs. Uterine sarcomas have very similar risk factors to uterine carcinosarcomas. Leiomyomas do not appear to be a precursor to leiomyosarcomas. Preoperative imaging, specifically with MRI and biopsy, may help identify uterine sarcomas, although the sensitivity is poor. Thus, many sarcomas are diagnosed postoperatively. Expert pathologic review is essential to diagnose and differentiate uterine sarcomas. The tumors are often large, being greater than 10 centimeters, with prominent cellular atypia, abundant mitoses, being greater than or equal to 10 per high-powered field, and areas of hemorrhage and coagulative necrosis. Leiomyosarcomas are the most common type as stated. They're very aggressive and have a high risk of recurrence and death regardless of stage at presentation. All subtypes of leiomyosarcoma express some level or combination of smooth muscle markers, including desmin, smooth muscle actin, and caldesmon.
The second most common are endometrial stromal sarcomas. These can be classified as low-grade or high-grade and are composed of cells resembling the endometrial stroma in the proliferative phase. Low-grade tumors have a heterogeneous mix of morphologic and genetic features, with up to half having JAZF1, PHF1, or EPC1 gene fusions, presenting as earlier stage tumors. High-grade endometrial stromal sarcoma are also characterized by fusion proteins, and they tend to have strong positivity for cyclin D1. Undifferentiated uterine sarcomas are high-grade aggressive tumors, which are characterized by infiltrative sheets of epithelioid and/or spindle cell cells, which can be uniform or pleomorphic. This is usually a diagnosis of exclusion, requires extensive IHC panels and next-gen sequencing. Adenosarcoma is a rare type of uterine sarcoma and is separated into adenosarcoma with or without sarcomatous overgrowth. This subtype includes a benign glandular epithelial component in conjunction with the malignant sarcomatous component. They're generally low grade and generally have relatively good prognosis. Most are stage 1 at diagnosis. A subtype with sarcomatous overgrowth includes tumors that are made up of greater than 25% sarcomatous tissue, and this subtype has an increased risk of recurrence and worse prognosis than their counterparts without sarcomatous overgrowth. Another subgroup of uterine sarcomas are characterized by SMARCA4 deficiency, which portends a poor prognosis.
Earlier, you said that uterine sarcomas are staged differently than uterine carcinomas. How so?
Great question. We won't belabor the details here, but one major distinction for endometrial stromal sarcoma and leiomyosarcoma is that the size of the primary tumor being greater or less than 5 centimeters makes the difference between stage 1A and stage 1B disease, as opposed to the myometrial invasion seen with endometrial carcinomas. Adenosarcomas have a different staging system than endometrial stromal sarcomas and leiomyosarcomas, but differences are confined to stage 1 disease, where myometrial invasion is considered.
Are sarcomas primarily managed the same regardless of their subtype?
Yes. Surgical intervention is similar for all sarcoma subtypes. For disease confined to the uterus, hysterectomy with en-bloc tumor resection with or without BSO is the standard of care. Because it's unclear whether BSO influences survival in patients with newly diagnosed leiomyosarcoma, it's often not performed in premenopausal patients. For patients that have endometrial stromal sarcoma, due to the hormonal responsiveness of these tumors, a BSO should be strongly considered. Limited available data suggests higher rates of recurrence for patients with ESS who do have ovarian conservation. For extrauterine disease, surgery also includes resection of metastatic disease. There's limited data that suggests that optimal cytoreduction, as in other uterine cancers, is associated with improved survival. For patients with disease not amenable to optimal cytoreduction, there's no benefit to surgery. In fact, surgery may paradoxically worsen prognosis if it significantly prolongs the time to initiation of systemic therapy. If the sarcoma is diagnosed postoperatively after a benign hysterectomy and a supracervical hysterectomy was performed, completion surgery with removal of the cervix should also be performed. It's reasonable to consider removal of the fallopian tubes or ovaries after risk-benefit discussion with the patient. Lymph node dissection is reserved for patients with evidence of enlarged lymph nodes on imaging, given that sarcoma primarily has hematogenic spread. Recall from residency that if power morcellation was utilized at the time of the original surgery, this can lead to widespread dissemination of tumor cells and upstaging. Power morcellators are no longer available in the US. Once patients are diagnosed with a uterine sarcoma and have had initial surgical intervention, how are treatment decisions made?
This largely depends on the subtype of sarcoma. Let's go over the upfront treatment of the different subtypes. We'll start off by discussing uterine leiomyosarcoma, the most common subtype of uterine sarcoma. The NCCN treatment algorithms for uterine leiomyosarcoma also include and are the same for high-grade endometrial stromal sarcoma, undifferentiated uterine sarcoma, and other sarcomas such as PCOMA. Treatment for leiomyosarcoma is primarily surgical, including the procedures we just discussed. After surgical resection of leiomyosarcoma, what are the recommendations for further treatment?
For patients that have completely resected disease, available evidence suggests no benefit to adjuvant treatment when compared to surveillance. Observation is the standard of care in a uterus-confined intact specimen. Multiple trials have evaluated adjuvant chemotherapy versus observation in patients with completely resected leiomyosarcoma. Compared to historically untreated cohorts, PFS did not appear to be improved with the addition of adjuvant therapy. These studies include GOG-20, which evaluated doxorubicin, Hensley 2009, which evaluated gemcitabine and docetaxel, and SARC-005, which evaluated gemcitabine, docetaxel, followed by doxorubicin. GOG 277 was a phase 3 trial which compared adjuvant gemcitabine and docetaxel and doxorubicin to observation. This study also showed no benefit to chemotherapy and actually had a worsened overall survival in the chemotherapy arm. Adjuvant radiation for uterine sarcomas, including carcinosarcoma and leiomyosarcoma, was evaluated in EORTC 55874, a phase 3 trial which randomized patients with stage 1 to 2 uterine sarcomas to postoperative EBRT versus observation. While radiation therapy reduced the risk of local recurrence in the carcinosarcoma group specifically, in no group was there a benefit in PFS or overall survival. What about patients who aren't surgical candidates?
There are multiple options for systemic therapy in uterine sarcoma. For a long time, doxorubicin was considered to be the first-line therapy for locally advanced or metastatic soft tissue sarcoma. Doxorubicin was compared against doxorubicin plus ifosfamide, palifosfamide, and ivosfamide, and no study was able to show a significant overall survival benefit. Then multiple studies specifically evaluating the use of gemcitabine followed by docetaxel in leiomyosarcoma were conducted and demonstrated activity of this regimen in both upfront and recurrent settings. These trials included Hensley 2002, GOG 131G, GOG 87L, Hensley 2009, and SARC 002. These two regimens were then compared in the Oesch trial, a phase 3 trial randomizing patients with advanced or metastatic soft tissue sarcoma to doxorubicin alone versus gemcitabine plus docetaxel. It included 71 patients with uterine leiomyosarcoma, 27% of the total patients. Both progression-free survival and overall survival were equivalent between the two regimens, and doxorubicin alone was less toxic than gemcitabine and docetaxel. Thus, it had less dose delays and reductions. The conclusions from this study were that doxorubicin alone should remain the standard of care for first-line treatment of locally advanced or metastatic soft tissue sarcoma. However, other preferred first-line regimens included in the NCCN guidelines are docetaxel plus gemcitabine, doxorubicin plus ifosfamide, doxorubicin plus dacarbazine for uterine sarcomas, due to no study demonstrating improved overall survival, but each of these have differing toxicity profiles. Even though doxorubicin was established as standard of care, outcomes for patients with advanced and recurrent uterine leiomyosarcoma were still poor, with a median progression-free survival of 23 weeks and a median overall survival of 76 weeks, or about 1.5 years. Maya, tell me, has anything improved this in recent years?
Yes. In 2022, the LMS 04 study was published. This was a phase 3 randomized controlled trial evaluating doxorubicin alone versus doxorubicin and trabectedin as first-line therapy for advanced or metastatic leiomyosarcoma. 67 patients, or 45% of overall patients in the study, had uterine leiomyosarcoma. Trabectedin is a compound derived from the C-squirt, which blocks the cell cycle at the G2-M phase by covalently binding to the minor DNA groove, bending the helix towards the major groove and inhibiting DNA transcription. After completing therapy, patients were allowed to have surgery for residual disease at the surgeon's discretion. With this therapy, the PFS doubled with the combination, up to 12 months versus 6 months, and overall survival data was still maturing at the time of publication. Hematologic adverse events were more common in the combination group, and 96% of patients in the combination group had greater than grade 3 adverse events compared to 52% in the doxorubicin alone group. Based on the results of this study, the combination of doxorubicin and trabectedin are preferred first-line therapy for uterine leiomyosarcoma. It's important to think about the patient's functional status and likelihood of tolerating the toxicities associated with this therapy. We've mentioned how high the recurrence rate is for uterine leiomyosarcoma. What options are available for treatment of recurrence?
Yes, unfortunately, the recurrence rate is up to 70%. There are options, but note that recurrent leiomyosarcoma has a really short progression-free survival and overall survival regardless of treatment. Based on the results of the SAR 3007 trial, Single-agent trabectedin is now recommended as the preferred regimen for recurrence in patients previously treated with doxorubicin or another anthracycline. This was a phase 3 randomized controlled trial which evaluated dacarbazine versus trabectedin. Trabectedin alone had a slightly improved progression-free survival of 4 months versus 1.5 months with dacarbazine. Overall survival was not significantly different between the groups. The PALET trial was a phase 3 trial evaluating single-agent pazopanib versus placebo in previously anthracycline-treated sarcomas, and we saw an observed progression-free survival of 4.6 versus 1.9 months in the leiomyosarcoma group. Study 309 evaluated the use of eribulin versus dacarbazine and observed an improvement in overall survival from 11.5 months to 13 months, and is also recommended as a 2B recommendation. Pembrolizumab is another option for patients with tumor mutation burden high tumors, and for leiomyosarcomas with BRCA mutations, PARP inhibitors can be considered. Other therapies which have been evaluated and not shown to have a benefit include olaratumab, sunitinib, and bevacizumab. That wraps up our discussion of uterine leiomyosarcoma. Maya, what about the less common uterine sarcomas?
The next most common type of sarcomas are endometrial stromal sarcomas. Remember that these are subclassified into low-grade and high-grade, and undifferentiated uterine sarcoma. We previously discussed that the treatment algorithm for high-grade endometrial stromal sarcoma, undifferentiated uterine sarcoma, and other sarcomas such as PCOMA are the same as for leiomyosarcoma. However, it's important to remember that systemic therapies do differ, as the studies for trabectedin were exclusively performed in patients with leiomyosarcoma. How does the treatment differ for low-grade endometrial stromal sarcoma and adenosarcoma without sarcomatous overgrowth, as opposed to their aforementioned more aggressive cousins?
Great question. The NCCN has treatment algorithms grouped together for low-grade endometrial stromal sarcoma and adenosarcoma without sarcomatous overgrowth, as they have similar histologic properties. Remember that adenosarcoma is a very rare subtype of sarcoma, and its staging does depend on myometrial invasion and grade, as opposed to the other sarcomas. Earlier in today's episode, we discussed logistics of surgical intervention depending on how the cancer is found. For stage 1 disease, the recommendation is for observation, as with for other sarcomas. For stage 2 to 4 disease, recommendations include the option of anti-estrogen therapy and consideration for EBRT. Aromatase inhibitors are the preferred regimen and can be considered for patients with sarcomas that are ER/PR positive with small tumor volume or slow-growing disease. If no previous BSO is done, ovarian suppression for premenopausal patients is needed. Other recommended options include fulvestrant, megestrol acetate, medroxyprogesterone acetate, and GnRH analogs. For medically inoperable sarcomas, options include systemic therapy and/or palliative EBRT with or without vaginal brachytherapy. Maya, what do we do when patients with endometrial stromal sarcomas recur or progress?
Options for recurrence depend on previous treatments and location and spread of recurrence. For low-grade endometrial stromal sarcoma or adenosarcoma without sarcomatous overgrowth, hormonal therapy is the first choice for systemic therapy. Otherwise, the same systemic options exist as for leiomyosarcoma and other sarcomas. In high-grade endometrial stromal sarcoma, there's really limited data, and most choices are based on research in undifferentiated soft tissue sarcoma. For local recurrences, if patients have had a prior radiation, options include systemic therapy. We could consider surgical exploration of potentially resectable disease or selected radiation. If there's no prior radiation, you can consider these options or EBRT plus minus brachytherapy and plus minus systemic therapy. Is there anything specific available for the other subtypes?
As we've seen, there are a lot of subtypes of uterine sarcoma. PCOMA and IMTs aren't always malignant, but do have the potential to be malignant. Malignant PCOMAs have a specific recommendation for albumin-bound sirolimus in the upfront setting. In the recurrent setting, sirolimus, everolimus, and temsirolimus are options. Additionally, there are several biomarker-directed therapies that are useful as both first-line and recurrent therapy for uterine sarcomas. Larotrectinib or entrectinib are available for NTRK gene fusion-positive tumors. IMTs are another spindle cell subtype that are often characterized by ALK gene rearrangements and may respond to ALK inhibitors.
Finally, we mentioned that a subset of uterine sarcomas are characterized by SMARCA4 deficiency. This is a SWE/SNF mutation that, when occurring in uterine sarcomas, portends a poor prognosis. Uterine sarcomas with SMARCA4 deficiency had a median disease-specific survival of 9 months. They tend to occur in younger patients. There are ongoing clinical trials evaluating targeted therapies for this mutation.
That's all we have for you today. We hope you learned something on today's episode of Ready, Set, GYO, a podcast for Gyn-Onc Fellows. Here are your key takeaways from today's episode.
Uterine carcinosarcomas are a rare subtype of endometrial cancer with poor prognosis. Treatment is similar to that for other high-risk endometrial cancers, with some additional options for chemotherapy, including ifosfamide and trastuzumab deruxtecan in special circumstances.
Uterine sarcomas are rare, difficult to diagnose preoperatively, and often have more aggressive behavior than their endometrial carcinoma counterparts.
Sarcomas use an entirely different FIGO staging system than endometrial carcinomas. Endometrial stromal sarcoma and leiomyosarcoma have a different staging system than adenosarcoma. The biggest difference for endometrial stromal sarcoma and leiomyosarcoma is that the size of the primary tumor is accounted for in staging, and myometrial invasion is not regarded. The adenosarcoma staging system is close to the old FIGO 2009 endometrial carcinoma staging, but also has some unique properties. Just remember to look these up when you have patients with these rare diagnoses.
Surgical cytoreduction is recommended in uterine sarcoma. There is no prospective data regarding the utility of a BSO. Early stage disease can be managed with observation.
In uterus-confined leiomyosarcoma, there's no clear benefit for adjuvant radiotherapy or chemotherapy, although randomized data are lacking for the latter.
Trabectedin has emerged as a novel therapeutic for leiomyosarcoma, both in the first-line and recurrent settings. There are additional options for treatment, but their treatment effects are not favorable.
Endometrial stromal sarcomas often show ER and PR positivity, and thus are responsive to hormonal therapy. They have not shown strong responses to traditional cytotoxic chemotherapies. This has been another episode of Ready, Set, GYO, your source for all things Gyn-Onc.
If you'd like to check out today's show notes, take some practice questions, or explore resources we use to create the podcast, head to readysetgyo.com, the companion website for our podcast. We encourage you to reach out if you have ideas for new episodes, questions or comments about existing episodes, or thoughts of how we can make this podcast even better suited for you. We're excited to continue to learn with you.
To stay up to date on all things Ready, Set, GYO, check out our Instagram and Twitter at ReadySetGYO.
To support us and our production of future episodes, check out our Patreon at ReadySetGYO.
This episode was recorded by Sydney Oesch and Maya Gross.
Our sound editor is Brogan Brown.
Our media and website manager is Sky Jacobson.
We'd like to thank Dr. Bunja Rungrang, faculty at the Medical College of Georgia, who reviewed the content of this episode for accuracy and completeness.
Sydney and Maya signing off.